Welcome to MS Monthly Report Series. I'm Rae-Grant, Director of this activity and Director of Education at the Mellen Center for Multiple Sclerosis. I'm delighted to introduce Dr. Francois Bethoux, physiatrist extraordinaire, who is Director of Rehabilitation Services at the Mellen Center for Multiple Sclerosis Treatment and Research at the Cleveland Clinic. He's been at the Mellen Center since his fellowship, continues to pursue research and teaching activities there. He is also the Editor-in-Chief for the International Journal of MS Care. Dr. Bethoux will talk about evaluating and treating gait disorders in MS. Dr. Bethoux.
I would like to thank Dr. Rae-Grant for inviting me to present on the evaluation and treatment of gait disturbance in patients with multiple sclerosis. The learning objectives of this talk are to describe the prevalence, clinical features, and impact of gait disturbance in MS, to identify validating measurement tools for the assessment and monitoring of gait disturbance in MS, and to recognize the components of the comprehensive management of gait disturbance. I will start by presenting a short case study. This is Susie, a 35-year-old woman who has been diagnosed with relapsing remitting MS, and she presents for a follow-up visit 6 months after being treated with steroids for an exacerbation of her MS. And her main complaint today is difficulty walking, which she did not have before the exacerbation, but now her right leg feels stiff and she has a limp. And when she's tired, she trips over her right foot, and she actually fell once trying to step up a curb because she couldn't clear the right foot. She used to jog for exercise, but now is unable to run. And she feels that as a consequence of being treated with steroids and being less active, she has gained 15 pounds. She is quite tearful and worried that she may end up in a wheelchair and asks if there can be any help. The question is, what is your treatment recommendation for Susie? A would be reassuring the patient. Since this problem was caused by an exacerbation, it will most likely improve. B, refer to physical therapy to work on her gait. C, prescribe baclofen to treat the stiffness in her leg. D, prescribe dalfampridine ER to enhance her ability to walk. Or E, advise the patient to start jogging again in order to lose weight. So in this situation, even though several of the recommendations could be valid, I would favor a referral to physical therapy. So that would be answer B. The rationale for this is, well, first, that 6 months after the exacerbation, it is less likely that her gait problem will resolve. It could still improve slightly, but it's likely to stay long-term. Therefore, it needs to be addressed. Prescribing baclofen to treat stiffness in the leg could be an option. However, we haven't confirmed on examination that there is spasticity in her leg and that this spasticity needs to be treated. So it would be a bit premature to prescribe a medication that by itself can cause side effects such as sedation or weakness. Prescribing dalfampridine could be also an option since it's indicated to treat walking limitations in patients with MS. However, the prime recently started and it may improve, and in particular with physical therapy and exercise. So my preference would go to holding off on prescribing such a medication until we know that we've reached a steady level of gait disturbance and assess if it interferes with the patient's activities. The last option doesn't seem to be rational at this stage since the patient has been unable to run and further justifies the referral to physical therapy. The patient is unable to use her usual mean of exercising and seems to be at a loss as to what to use for exercise in order to stay healthy, stay in shape, and hopefully lose the weight that she has gained over the past few months. And the guidance from a physical therapist would be very helpful in helping her design her own stretching and exercise program and then continue it on her own at home. Physical therapy can also help her with gait training and decide if there would be any other management options for the problem with her right foot that seems to make her trip and fall. Walking limitations in MS are a common problem. Numbers vary, but up to 75 to 80% of individuals with MS experience walking limitations at some point in the course of their disease. And instrumented measurements of walking and balance have demonstrated that gait disturbance and loss of balance can be detected early in the disease, even at the stage of clinically isolated syndrome compared to healthy individuals. Even though these disturbances may not be noticeable on a routine clinical examination. It is also well known that walking limitations have a widespread impact on daily activities, psychosocial status, and the quality of life of individuals with MS and their loved ones. And in one survey of about 200 MS patients in Germany, lower extremity function was ranked as the most important function by a majority of the patients. And this ranking did not change whether the patients were early in the course of their disease or later in the course of their disease. So this shows that both from the physician's or healthcare provider's perspective and from the patient's perspective, it is important to recognize and address gait disturbance and walking limitations in patients with MS. Fortunately, there are a variety of treatment options for walking limitations in MS. And these are listed on this slide. Exercise is one that is often proposed. Rehabilitation is linked to exercise, but is a more formal and skilled intervention that will guide the patient in developing an exercise routine, but also includes other modalities such as guidance and training to the use of assistive devices. As mentioned before, medications can be used, and we will come back to this later. In some cases, surgical treatment may be needed to improve walking, such as when there is a severe orthopedic complication or possibly with severe spasticity as well. Psychosocial management can be an ongoing option throughout the course of management to monitor the consequences of walking limitations and to try and minimize them. There is extensive literature on the consequences of loss of mobility on employment, for example. And since MS affects many young adults, it is important to make sure that we try and preserve employment as long as possible, despite the walking limitations. The effects of exercise on walking in MS have been documented in case series and clinical trials. There are several modalities of exercise training. The main ones are aerobic training, such as walking or running on a treadmill or using an exercise bike. Resistance training has been promoted more recently in MS, involves using weights or elastic bands or other means to perform a movement against resistance and try and improve strength. Task-specific training is also important. In the case of walking, task-specific training involves gait training, possibly also balance training, and it involves performing a series of tasks that will retrain the gait pattern to hopefully improve it, make it more efficient, make it safer, and help improve daily activities. Finally, training can be enhanced with technology. This is a relatively new development, but the number of options is increasing rapidly. The problem is that these options have not always been thoroughly tested, and it is not always established that these are superior to one-on-one training with, for example, a physical therapist. A meta-analysis of the effects of exercise training on walking in patients with MS showed a small but significant effect on walking performance among a variety of exercise interventions. Of note, the majority of studies involve patients with low levels of disability, which shows that there is a need for further research on patients with higher levels of disability, which very much are in need of exercise. So if we go back to our case study, 5 years later, the patient comes back to our office for a routine follow-up visit. She has been exercising on a regular basis, but she reports that over the past year, she has been increasingly bothered by her gait disturbance. She walks more and more slowly. She needs to sit down more often. She cannot walk the same distance that she used to walk, and her right leg feels weaker and stiffer than it used to. And she has started to notice similar problems with the left leg, although they are more minor. She frequently trips over her right foot, has fallen several times every week, and tends to use walls and furniture for support in her home, or her husband's arm for support when she walks outside. In addition to these complaints related to her gait, she complains of painful muscle spasms in the legs, which wake her up 3 to 5 times every night. So the question is, which steps could be helpful in addressing Susie's gait disturbance at this stage? Obtain a quantified measurement of walking performance and to monitor it over time, to refer the patient to physical therapy, to prescribe an assistive device, to prescribe a medication for spasticity, to prescribe dalfampridine ER, or all of the above. In this case, my answer would be all of the above. All of these are reasonable options in the management of this patient's problem. The main question is how these treatments will be coordinated, possibly combined, or scaled over time so that we achieve the best combination to improve the patient's gait. At this point, the main concerns are the safety of the patient's gait, since she falls frequently and may injure herself over time. Also, the lack of efficiency of her gait. She obviously needs extra attention and extra effort to clear her right leg when she walks. And also, the third concern is that her mobility is significantly limited. It seems that she can only walk outside if she's in the company of her husband, which means that she mostly stays in her home over the course of the day. So we will go over some of these steps in the following slides. The next question is about walking tests. So assuming that we want to assess and monitor in a quantified manner this patient's walking performance, which one of these walking tests is or are also useful to evaluate balance? The timed 25-foot walk, the 2-minute walk, the timed up and go, the 6-minute walk, or A and C, which would be the timed 25-foot walk and the timed up and go. So the answer is C, the timed up and go. As of now, the timed up and go, or TUG, has been the only test proven to being helpful in assessing balance as well as gait, which can make it an appealing option when a healthcare provider wants to assess and monitor walking but also balance in a patient. Briefly, the test consists of having the patient sit on a chair, stand up from the chair, walk a short distance, turn around, walk back, and sit back down on the chair. So there are several steps and movements involved in that test, as opposed to most other walking tests that involve walking in a straight line on a level surface over a certain distance or over a certain time. There are many options to quantify and monitor gait and walking in patients with MS, and many of these tests or scales or questionnaires have been validated. The most popular are the performance tests, because some of them take very little time, space, or equipment to perform, and they can be easily monitored over time. The most popular is the timed 25-foot walk, which has been extensively validated in MS. And actually there is a commonly acknowledged value for a clinically significant change in the timed 25-foot walk, which is a 20% change. But the timed up and go can also be used, as mentioned before, or the 2 or 6-minute walk tests, which are conceived more of as tests of walking endurance. So they may shed a different light on the patient's performance, whereas the shorter tests are more focused on walking speed on a short distance. Clinical rating scales are less often used to monitor walking. The Expanded Disability Status Scale, or EDSS, is actually heavily focused on walking in the second half of the scale. However, it often is found to lack sensitivity when you want to closely monitor walking performance, either in the progression of the disease or as a result of interventions that are supposed to improve walking. The same could apply to the ambulation index. The dynamic gait index is more often used by rehabilitation professionals and involves having the patient walk while performing a series of maneuvers that can compromise their dynamic balance during walking. Gait analysis necessitates instrumentation. Therefore, the need for equipment, time, and personnel limits its use, and it is rarely used in common clinical practice. However, there are some devices that have been commercialized and that allow a quick and efficient evaluation of basic gait parameters such as velocity, cadence, or step length. Common findings in gait analysis in MS show that patients walk more slowly compared to healthy controls with a decreased cadence and shorter steps or strides. At the same time, the double support phase, the phase during the gait cycle where both feet are on the ground, is increased, and gait parameters are more variable. So there's going to be more dispersion of these values around the mean over the course of a walk. Recently, activity monitors have garnered increasing interest. Sometimes these devices are called wearables, and that's where their advantage is. They can be worn by the patient while they walk in their own environment, while all of the other tests are performed either in the clinic, in a rehabilitation facility, or in a laboratory. These activity monitors can be worn in the patient's own environment and give us a more accurate picture of how much walking they do on a daily basis, but also which times of the day they walk most and which level of effort they accomplish throughout the day and night. Self-report measures are very important since it is important to get the patient's point of view on their walking limitations. The one scale that has been the most extensively validated in MS and that is the most commonly used, including in clinical trials, is the MS Walking Scale 12. As its name indicates, it consists of 12 items rated. As its name indicates, it consists of 12 items and investigates common aspects of walking limitations due to MS. One interesting aspect of walking limitations in MS is the dual task cost. It is now established that when patients with MS try to perform a cognitive task during walking, their gait deteriorates. They walk more slowly, and some of their gait parameters change and become more variable. This is also seen in healthy individuals as part of multitasking, but seems to be more common and more pronounced in patients with MS. And this has been suggested as an important outcome in rehabilitation trials, but the jury is still out as to the utility of these measures as opposed to simple walking tests. Their advantage would be obviously that they may be closer to real-life situations where patients can often get distracted while walking by, for example, somebody talking to them or by the presence of an obstacle that they have to deal with. The next question is, which of these clinical parameters have been shown to correlate with gait parameters and walking performance in MS? Muscle strength, spasticity, fatigue, neurological disability as measured with the EDSS, ABND, which would be strength, spasticity, and neurological disability, or all of the above. So in this case, the answer would be E. Muscle strength has been shown repeatedly to correlate with gait parameters such as gait velocity and step length. Spasticity has also been shown to correlate with walking performance. However, most, if not all, patients with spasticity have some level of weakness at the same time, and it is often hard to tease out how much of the gait disturbance is related to spasticity or to weakness. In addition, there is little evidence regarding the impact of treatments for spasticity on walking performance. Neurological disability as measured with the EDSS has been consistently reported to correlate strongly with walking performance and with gait parameters. Fatigue, somewhat surprisingly, does not consistently correlate with walking. There are several possible explanations for this finding. One is that fatigue is a subjective finding that may not be fully related to physical performance. In one large clinical trial, multi-center clinical trial of over 100 patients with MS, showed that despite a worsening of fatigue throughout the course of the day, walking performance did not decrease on average on the patient sample. This does suggest that as patients feel more tired, their walking performance may not necessarily diminish, or at least not in a measurable way with our current tools. There is one form of fatigue called physical fatigue or motor fatigue that may correlate better with walking performance, but it needs to be further evaluated. So if we step back and look at all the factors that may impact walking in MS, we see that there can be many. The main factor, obviously, is the disease process. As MS causes damage to the central nervous system, it causes a variety of impairments which we have touched upon previously that result in impaired walking. In addition, people who have impaired walking often get deconditioned. They get out of shape because they do not exercise or simply move around as much. They are not as active. And this actually adds to their walking limitations. Medication side effects can also play a significant role. For example, some medications may cause increased weakness or may cause sedation that will lead the patient to be less active or less mobile. Comorbidities emerge as a very important factor, and it could be cardiovascular, respiratory, or often musculoskeletal comorbidities. Patients who have an altered gait pattern are at higher risk for developing early osteoarthrosis or simply pain, joint pain, muscle pain, that is not directly related to the MS but are a secondary consequence of their altered gait pattern, and that may in turn aggravate their walking limitations. There are also personal factors. Some individuals do not like to be active or exercise, and environmental factors. They can be physical obstacles to moving around. For example, if somebody needs to climb up and down several flights of stairs to get in and out of their dwelling, then they may be more reluctant to go out and walk, for example. And a ramp or an elevator may resolve the problem. The next question has to do with evidence regarding interventions for walking. So although there are many interventions that we have listed before, the evidence to support the use of these interventions is not always present. So for which interventions was the effect of walking deemed to be inconclusive based on a literature review? Physical therapy, assistive devices, treatments for spasticity, dalfampridine ER, or exercise. So the answer to this question is C, treatments for spasticity. There have been several studies of various treatments for spasticity in MS, and certainly the amount of evidence is not sufficient, and the quality of the evidence has been deemed insufficient as well. But a very thorough review of the literature published in 2003 concluded that the evidence to support a functional impact of spasticity treatments in MS was inconclusive. And more recent literature reviews have come to the same conclusion. So we cannot really state from there that spasticity management has no effect on walking or gait, but that the evidence is insufficient and there needs to be more clinical research to further elucidate the question. All of the other treatments have been found to some degree and at some level to have a positive impact on gait and or walking. There are many assistive devices that can be prescribed to enhance walking in patients with MS. Frequently, MS patients are reluctant to use these devices. For some of them, they may get a feeling that they're giving up or giving in to the disease by accepting to use a device. And there's also a concern that this makes an individual look more disabled or feel more disabled as well. The flip side, the counter-argument would be that, of course, these devices can improve the safety and efficiency of walking, may allow actually the person to walk more often and longer distances, and possibly without having to rely on others to get around, therefore may increase their independence. Commonly prescribed mobility devices include walking sticks, canes, walkers, power scooters, manual or power wheelchairs. And which of these devices is prescribed will depend on the patient's level of disability, of walking disability, obviously. And often, input from a physical therapist is helpful in deciding. Often, input from a physical therapist is helpful in deciding which device would better fit the patient's needs, but also to train the patient to the safe and efficient use of this device, so that hopefully they will keep using it in a consistent and safe manner over time. Orthotics can also be very helpful. The ankle-foot orthosis is very commonly prescribed for foot drop related to a combination of weakness and spasticity. That is a fairly common problem in patients with MS, which leads to decreased clearance of the foot. So, for example, in the case study referred to before, an AFO may have been helpful for this patient to avoid tripping over her right foot and falling. One of the limitations of the ankle-foot orthosis is that it only addresses problems at the level of the ankle and foot, and possibly also helps correct problems with dynamics at the knee. But patients with MS often exhibit weakness in the hip flexors, and for this reason, the hip flexion assist device has been developed and is now available and helps assist active hip flexion, therefore provides further assistance with clearing the foot while making steps or climbing upstairs or climbing up a curb. Functional electrical stimulation, or FES for foot drop, is actually commercially available. There are several devices that are available on the market. They can be very useful because they promote active dorsiflexion of the foot, which is timed to the gait cycle and can help in an active manner with foot clearance. However, these devices have limitations, and one of them is their high cost and the fact that in the United States it has been difficult to obtain insurance coverage. In addition, there can be technical limitations to their use, or some patients may have difficulty finding consistently the points of stimulation to promote an effective dorsiflexion of the foot. Exoskeletons have been proposed more recently, mostly in patients with spinal cord injury, but there are ongoing research studies in patients with MS. This is a more recent technology, and at this point, it has not been approved by the FDA, to my knowledge, for use in patients with MS, but could certainly be interesting in patients with very limited mobility by providing external power, basically, to move the legs and allow people to walk longer distances in a safe manner. At this point, exoskeletons remain investigational devices in MS. The next question is focused on dalfampridine ER. Which statement or statements regarding dalfampridine ER is or are incorrect? Dalfampridine ER is indicated in the US to help improve walking in individuals with MS and is prescribed at the dose of 10 mg twice daily, 12 hours apart. Dalfampridine ER is contraindicated in patients with moderate or severe liver failure. Phase 3 clinical trials of dalfampridine ER showed an improvement in walking speed using a responder analysis. Seizures were the most common adverse events in clinical trials of dalfampridine ER, B and D, or B and C. In this case, the answer regarding statements that are incorrect would be B and D. Dalfampridine ER is indicated to improve walking in individuals with MS based on improved walking speed in phase 3 clinical trials. Dalfampridine is primarily cleared through the kidneys into the urine and is contraindicated in patients with moderate to severe renal failure. And it is recommended to obtain an estimated creatinine clearance before prescribing the medication. And although seizures are a potential side effect of dalfampridine ER, and certainly a concerning potential side effect, they actually were observed rarely in clinical trials, and recent numbers from post-marketing surveillance do not indicate that they are a common side effect of dalfampridine ER. However, it should be kept in mind that patients with a past history of seizures should not be prescribed dalfampridine ER. This question is a nice segue into pharmacologic treatments that can improve walking in MS. First and foremost, disease-modifying therapies are expected to have an impact on walking by preventing either relapses or slowing down the progression of impairments from the disease process over time. However, it is not usually expected that initiating a disease-modifying therapy will lead to an improvement in walking. Symptomatic therapies that impact impairments that can contribute to walking impairment can be helpful. The impairment for which there's the most options is spasticity, but as I said before, there's inconclusive evidence as to the effects of spasticity management on walking. Actually, one of the side effects of medications for spasticity can be increased weakness, which then may lead to actually increased difficulty walking. So that does not mean that treatments for spasticity should not be used in patients who have walking limitations and significant spasticity. For example, the patient that was presented earlier complains of muscle spasms at night that disrupts her sleep. Therefore, it would make sense to prescribe a low dose of an antispasticity medication such as baclofen or tizanidine, at least at bedtime in this patient, so that she can have fewer spasms and better quality of sleep. The question would be whether the same medication could be or should be prescribed during the day, and that's where the pluses and minuses of prescribing the medication during the day should be carefully weighed. Dalfampridine ER, as stated before, is indicated to improve walking in patients with MS. In general, the clinical trials have shown that roughly between 35 and 42% of patients with MS exhibited a consistent improvement of walking speed while taking dalfampridine ER. This shows that not every patient is expected to respond to the treatment. However, a substantial percentage of patients are expected to benefit from it. I want to point out that the dosage of dalfampridine ER is 10 milligrams twice daily, and as much as possible 12 hours apart. And it is not recommended to increase beyond that dosage. And also patients should be taught to not try to catch up if they think they've forgotten a dose or if they're not sure that they have taken the last dose, in order to avoid any overdosage. Phase 2 clinical trials have shown that in higher doses of dalfampridine ER did not seem to provide additional clinical benefit, but did result in increased risk of side effects, including seizures. The most common adverse events noted during the clinical trials of dalfampridine ER are listed on the slide. So in conclusion, gait disturbance and walking impairment are a common consequence of MS and have a widespread impact on the functional status and quality of life of individuals with MS. Damage to the central nervous system caused by the disease is the main cause for the gait disturbance and for the walking limitations, but there are many other internal and external factors that are involved and that can be the target of interventions. There are validated instruments to assess and monitor walking performance and gait disturbance in MS, and it is recommended to use one or several of these instruments to monitor patients over time and to get a better idea as to whether their gait disturbance or walking impairment is worsening over time, is stable, or is maybe improving as a result of an intervention. And it has been recommended in literature reviews to combine an objective test of walking performance, such as the time 25-foot walk or the time up and go, and a self-report measure such as the MS Walking Scale 12. Finally, a variety of interventions are available to address gait disturbance and walking limitations in MS. Their use is supported by a growing body of evidence. There's a clear need for further research on many of these interventions, and it would be very interesting in the future to see head-to-head comparison trials of various treatment modalities. But at this point, there is enough clinical experience to warrant the use of many of these interventions. The question is to individualize the treatment plan and to have a goal-oriented and comprehensive management approach, and to have a clear agreement with the patient on what realistic goals entail. I have seen in my experience many patients give up on interventions because the improvement that they actually experienced, which could be objectively observed, did not meet their goal. And it is hoped that with a clear discussion of the goals before initiating the treatment, the patients would be more inclined to stay on a treatment that is shown to be beneficial and does not cause side effects, obviously. I thank you for your attention.
Thanks, Dr. Bethoux, for your expert analysis of gait evaluation and treatment. It's clear that there's much more to MS care than just the disease-modifying therapies, and attention to gait issues are one of the most critical areas. There is good data to support the notion that gait abnormalities are one of the major concerns for people with multiple sclerosis, and we probably don't pay enough attention to this issue in the clinic visit. Your talk emphasizes that we need to focus on multiple factors, including medications, comorbidities, environmental factors, fitness, and the disease process, in fashioning a rational therapy for gait problems in MS. You also emphasize the large group of treatments and devices which can be brought to bear after a careful gait analysis.